Hello, and welcome to this evening's RLI Power Hour webinar titled International Outreach. My name is Dr. Jennifer Nathan, and I will be co-moderating this evening session with Dr. Bob Pyatt as we are co-chairs for the RLI Power Hour webinar series. So before we get started, we do want to let you know about some logistical items so that you know how to better participate in this evening's event. So when you join this evening, you join through the Zoom platform. At the very bottom of your Zoom window is the Zoom control panel, which you can see an image of it here. There are two icons that we want to draw your attention to on the control panel. The first is the chat icon. This is the icon right here I'm showing you. You would use that icon if you're having technical issues. So if you're having technical issue, click on the chat icon, up comes the chat window, you type in your technical concern, hit send, and then our support staff will be reaching out to you to help you resolve your issue. The second icon I want to draw your attention to is the Q&A icon. This is what you would use to submit questions for our faculty to answer. You are welcome to submit questions at any point during the webinar. However, they will be collected and not addressed until we get to the dedicated Q&A session at the very end of the webinar. Last item that we do want to let you know about is that this is a webinar that will be recorded and will be available to our membership at a later date. That also includes the Q&A component, so all questions will become part of that recording. So I'm now going to turn things over to Dr. Pyatt to introduce this evening's faculty. Dr. Pyatt?
Thank you, Jen. We are delighted to have four distinguished faculty with us this evening, and I want to do a brief introduction for each of them. Time does not permit me to go into too much detail in their bios, but we have some incredibly experienced faculty. Our first speaker is Kristen Distinctor, MD, FACR. She is the John P. and Catherine H. Tampus Green and Gold Professor and Chair of Radiology at the Larner College of Medicine at the University of Vermont and the Radiology Healthcare Service Chief for the University of Vermont Health Network. She received her MD from Case Western University School of Medicine and completed her diagnostic radiology residency and fellowship in body imaging and women's imaging at University Hospitals Cleveland. She has expertise in world health, specializing in lower to middle income economies. Dr. Distinctor is the recipient of the RSNA 2016 Outstanding Educator Award, given to one individual each year and considered the most prestigious international educator award in the field. She is the 2020 recipient of the APDR Lifetime Achievement Award as well. Drawing upon her experience in international radiology, education, and leadership, Dr. Distinctor co-founded a nonprofit organization, Imaging the World, in 2008 that specializes in integrating low-cost ultrasound programs into remote health clinics where radiologists, technologists, and the usual infrastructure required of imaging systems are lacking. The website is www.imagingtheworld.org if you're interested. Through her work over the last 14 years, clinical facilities in rural Uganda and Malawi have access to reliable ultrasound imaging close to home for many patients. The program is supported by grant awards, including from the Bill and Melinda Gates Foundation. In 2016, Dr. Distinctor received the American College of Radiology Foundation Global Humanitarian Award for her outstanding work to improve medical imaging and access to care. In addition, she received a certificate of recognition from the Uganda Society for Advancement of Radiology and Imaging for providing invaluable resources towards improving breast cancer diagnosis and management in Uganda. More recently, she received the 2018 University of Vermont Citizen of the World Award from the Larner College of Medicine. She was the 2020 keynote speaker for the opening ceremony of the RSNA, speaking on the power of radiology to drive collective action and to transform global health. Dr. Frank J. Lexa, MD, MBA, FACR, is the author of the book Leadership Lessons for Success in Healthcare, which takes a systematic approach to developing medical leadership skills. He is an academic neuroradiologist and is currently a professor and vice chair for faculty affairs at the University of Pittsburgh, where he also does global radiology work for UPMC internationally. Previously, he served as a professor and the associate chief and vice chair of strategy and development at the Department of Medical Imaging at the University of Arizona. He began his career in France with a visiting position at the University de Bordeaux and has been a clinical professor at the University of Pennsylvania School of Medicine and a professor of radiology at the Drexel University College of Medicine, where he was also the vice chair. Dr. Lexa has been honored with several major scientific research awards, including the Cornelius G. Dyke Memorial Award of the ASNR. He also works outside of academic medicine and was a member of the adjunct faculty of the Wharton School of University of Pennsylvania in the marketing department for 17 years, where he taught both graduate and executive MBA students in the global consulting practicum. This took him to 5 continents. In the GCP, he served in multiple leadership roles, including Spain, United Arab Emirates, Israel, and country manager positions in the East Asia region for mainland China and Taiwan. Dr. Lexa has served on the Board of Chancellors of the ACR for 2 terms as chair of the Commission on Leadership and Practice Development. He is the Chief Medical Officer of the RLI. He is also the current chair of the ACR International Economics Committee and a member of the ACR International Commission. He was educated and did his medical training in Boston, the San Francisco Bay Area, and in Philadelphia. Frank is a licensed airplane pilot and an avid skier and scuba diver. He has raised money for several charities in multiple ways, including 100-mile ride for MS research. In his spare time, he bikes and chases after his 2 Portuguese water dogs, Rocky and Gabby, and his potbelly pig, Piper. Dr. Dan Molinera, MD, is a founder and CEO of RadAid International, which is a nonprofit organization for increasing health and radiology medical care to underserved and resource-poor communities. Dan received his MD from Johns Hopkins University, and he did his radiology residency in diagnostic radiology and fellowship at Johns Hopkins. Based on his background as a Goldman Sachs financial analyst and prior founding of 3 other startups, which were successful in the media, technology, and public sectors, Dr. Melora founded and led RadAid for over 13 years to become a global nonprofit organization with nearly 15,000 members, serving 90 hospitals in 40 countries. In addition to his 10 years at Johns Hopkins, Dr. Melora served for 10 years on the radiology clinical and research faculty at the NIH in Bethesda, Maryland. Brad Short is a vice president of governance and member services for the ACR, and he's the primary professional association, which is the primary professional association of radiologists in the United States, as we all know. Mr. Short holds a Bachelor of Science degree in public administration from George Mason University and a Master of Arts degree in legislative affairs from George Washington University. Mr. Short has worked in government relations, chapter services, governance, member services, meeting services, international outreach, and volunteer services during a span of 34 years at the ACR. Having witnessed the growth and development of the organization for over 1/3 of its existence, Mr. Brad Short has been tapped to staff the ACR's centennial celebration at the 2023 and 2024 annual meetings. It is a pleasure to present these 4 tremendous faculty for you tonight for this program. Thank you. We will start with Dan Melora.
Hi, everyone. I'm Dan Melora. I'm the CEO of RadAid, and I want to thank you for joining us today. And I want to thank the Radiology Leadership Institute of the ACR for putting together this meeting and for inviting me to present. So when we were all brought together for this, we were told by RLI that we would be giving stories about our experience in global health. And I have to admit, I was a little overwhelmed, not really sure where to start, because RadAid has been around now for 14 years and has worked in 40 countries and 91 hospitals. So there are actually a lot of stories to tell. And among the volunteers, there's close to 15,000 volunteers now. And there's so many stories that have come out of these experiences. So if you look at these pictures, Dr. Chip Sweat standing on that shelf in Ghana. How did he get there and what's he doing there? Or Morocco, how did we get involved in supporting this mobile health truck in Morocco? Or this team picture from the Zatari refugee camp in Jordan, and all the stories that went into working on Asha Jyoti, the mobile health truck in India. If you see in the center picture on the bottom, Rad Aid USA working in Virginia in sort of a tent-based open air clinic kind of scenario where there's an ultrasound station in these free charitable clinic events, or in Malawi where we were providing technologist education. So many stories. So I was trying to think about ways to bridge the stories into things that may be useful to you. And it came to a question that we commonly encounter of what characteristics make a global health volunteer most effective. And if you think about it, these characteristics are linked to the stories because they show us what works and what types of approaches could be helpful to you. So here they are: procedure, patience, principle, and perseverance. 4 characteristics I've seen over and over that drive successful projects forward. And I hope you don't mind a little alliteration here just to help us all remember these things: procedure, patience, principle, and perseverance. So let's start with procedure. Well, over half the world lacks radiology. So a lot of these scenarios can seem pretty overwhelming when you first step into them. Here's a picture from the Dominican Republic that comes from Diana Dowdy, part of Rad Aid's management team. And you can see that this is an ultrasound clinic. It's outdoors. It's in a barn, actually. And this was designed for women who are pregnant in Dominican Republic to receive ultrasound and prenatal care. So how would you approach a scenario like this? And how would you address this kind of setup for providing medical imaging? Here's some pictures from Rad Aid Ghana, and you can see that there's clearly some equipment challenges back in 2012. So how would you approach a scenario like this one? It can seem almost chaotic because you have so many equipment needs and so many places that you could begin working that you might not even know really where to start. Here's another example in India where the volumes are so high and so many people need your help that you see scenarios like this one, which come from the Asha Jyoti Rad Aid program in Chandigarh. So our approach that brings us back to procedure is radiology readiness. And this is an assessment tool that we've been using since 2008 and 9. And it starts off with the question, what does a site have? And then we look at its goals, because by starting off what they have, you can optimize what they already have to reach those goals. So it's all about bridging the haves and the goals by filling in gaps. Well, that means an assessment, and these are all the different sections of that due diligence step that you take to look at how can radiology be effective in this type of context. And every program looks this way. So it starts off with the radiology readiness assessment, and then we work with the partner institution to come up with a plan and then implement that plan with training and analysis and innovation. And it goes round and round in that cycle of matching up what they already have to new resources so that we can bridge what they have to their goals. So here's an example. Here's a story from that. The founders of Friends Without a Border had called me in 2015 telling me about the new hospital they just had built in Laos, Lao Friends Hospital for Children. And they asked us for help with the radiology department there. So we start off with the radiology readiness assessment, and well, what did they have? They had a new pediatric hospital, comprehensive health. The goals were to provide medical imaging to go along with those services for the children. But the gaps was that the radiology department, when we went there, was essentially an empty room. Our team found no equipment, no personnel, no imaging staff, educational pathways. So now we're going to fill those gaps by building from scratch, essentially, a radiology department with new equipment, personnel, and digital imaging capabilities. So here we sent over 25 rotating teams into Lao Friends Hospital for Children, donating ultrasound, sending teams for X-ray, and then also moving past film and donating a PACS with support from Ambra Health and Google Cloud. Here's some IT volunteers in Rad Aid that implemented this PACS. And then later we even implemented CT, which you show here through a partnership in which we were able to get access to CT services for the children by going to an adjacent adult hospital that was nearby. So the second feature, that can make global health volunteers very effective is patience. Here's an example from Radiology Kenya. You know, we all would love to accomplish things overnight. We want to get things done right away. And, you know, sometimes it takes time, and we have to listen, and we have to spend time in diplomatic humility as we listen to what kinds of problems are out there and what can we solve. So here, this example, this is Dr. Bob Dixon with a team from IR, Radiology IR at University of Nairobi. And we found that there were fewer than 10 radiologists in IR for all of Kenya, which is about 50 million people. So here we were, you know, our teams there working in Kenya, and we found that, you know, to start an IR fellowship would be a 2-year journey. We would have to plan out the curriculum, get design and approval from the university, and then we had to do memorandums of understanding, the agreements between the institutions. So we tried a tripartite approach at first, involving several universities. And then we realized, well, that wasn't working. So we needed to meet all the needs of all the partners by having bilateral agreements. And here it was being launched in 2020. Dr. Dixon and Dr. Elijah Kwasa announcing this at the Kenya Association of Radiologists meeting. This was during COVID, and that's why it's in a virtual format. And now we also introduced tele-IR simulation training to overcome the COVID barriers so that we could do simulation-based instruction for the new fellows that had begun our program. And now this year, April and September, we're sending team trips back to Kenya. We're doing PACS donation at University of Nairobi. There will be IR nursing components because nurses will be volunteering on the IR teams. And we will be administering the first ever oral exams for the graduating IR teams. So it's really important to think about patience, the long view, and how these steps may take time. And just by listening and being diplomatic, we can accomplish really important things. Now, the third is principle. You know, in global health, there's a lot of expectations, and sometimes there's even a lot of hype. So AI has been one of those things full of promise, hopes, but sometimes even hype. So here's the cover of Economist magazine talking about AI, radiology, and the future of work, or AI hype in radiology, this article that was published. So to overcome hype, noise, and expectations, we have to stick to our principles. What's the right thing to do? So as you know, we've been donating PACS through the Radiology Friendship Cloud, which you see here has a local server and cloud backup architecture. But we stick to our principles by going through a similar process of teach, try, use. So teaching means teaching basic radiology, image interpretation, but also teaching AI, such as appraising AI outputs, how to supervise AI implementation. And then try part, it means donating infrastructure like PACS, RIS, IT infrastructure, cloud, and then use is gradually rolled out in a way that's responsible so that we can account for things like data privacy or how we can make sure that we trust the systems. We look for biases. We look for areas where it might not be performing so well so that the use is very gradual. So here's an example, a story that comes from Radiology Nigeria at University College Hospital. It started off with printed film here in 2018. We then donated the PACS and we worked with them for computer workstations. They were even so nice, they even named the reading room after us because we were working with them in putting this up. But then what we did was we donated the AI that you see here. This was a scenario where the film was being interpreted by Cure.ai, generously donated here so that we could try out how it would work in these scenarios. So here's the impact. You move from printed film to PACS and then to AI. Here's another example with a contribution from Kios Medical for ultrasound AI support. We did this in Peru and Kenya following the teach, try, use process. And here's another example that was supported by Densitas, which provides AI for giving feedback to the technologists so that they can look for image quality when producing mammograms. And these images come from Guyana. So the last is perseverance. You know, we all experience disappointments and setbacks, and it's so easy sometimes to really want to give up. And we put in our mission statement, you can see here it's circled, always persevere, because we knew even back then it would take a lot to overcome those disappointments and make sure that we could continue working towards the goals. So here's an example from Radiology Guyana. We started in 2013 We went with the Pan American Health Organization. We worked on site. And, back then during these initial visits, we weren't really able to accomplish all that much. We weren't really able to formulate a program. We weren't able to get the partnerships going. Well, in 2016, Jill Bettino, who was leading Rad-Aid Nicaragua at the time, asked me, can we send a team back to Guyana and try again? So that's what we did. Here's Jill Bettino, and she went back in 2016 and reached an initial agreement with the Public Health Department, Guyana's Ministry of Health, on how to move forward. And, one of the things that came from this and the radiology readiness assessments is that Guyana really needed a radiology residency because there were no in-country radiologists being trained for Guyana. So we started that process in 2016 into 2017. And here were the first crop of radiology residents that we are now supporting. They came to the Rad-Aid conference in 2017. Here's another picture of them in front of the Lincoln Monument, which occurs. Lincoln Monument is about down the street from where the Rad-Aid conference is. And here we are meeting them in 2017 to begin supporting them for residency. We also donated and implemented CT. Then we trained nurses and technologists for CT services in Guyana. Then we donated PACS, which converted this room on the left into the digital imaging workstations you see here on the right. And here in 2020, the first ever graduating radiology residents in Guyana. So it's extraordinary the way it went from 2013, where it was so disappointing. We didn't really think we could move forward. And here we are in 2020 with all these people now pursuing their dreams and building futures as radiologists. So the last thing I'll say here is that procedure, patience, principle, and perseverance, those are the characteristics that we've really seen be very successful in global health volunteers. And I show you also this Rad-Aid flywheel of how we integrate operational expertise with regional expertise. So regional leaders in blue interfacing with the local institutions to bring teams and help work with local partners, and then having operational expertise such as ultrasound, IR, women's health, IT, et cetera, and then integrating those. So these features that I'm talking about, procedure, patience, principle, and perseverance, they come from this interconnectedness among the teams. So I want to thank you all for listening to this presentation and for joining this RLI webinar. And I hope you'll consider joining us in Rad-Aid.
Thank you so much for this invitation to present to the RLI Power Hour. I have no relevant disclosures. My role during the past 14 years as co-founder and director of Imaging the World, a nonprofit organization, is entirely on a volunteer basis. I have no financial interest. On a personal note, my introduction to global health was many years ago when I was at Case Western Reserve University as a research assistant. Working with a research team on the phase 2 drug study for praziquantel for schistosomiasis in rural Kenya in the 1980s, I was inspired by a Kenyan radiologist to solve an access problem for pregnant women needing ultrasound. Many years later, with another radiologist, I founded Imaging the World. The mission of Imaging the World, or ITW, is to expand access to diagnostic imaging in the world's most resource-limited locations, with the vision of reaching 15 million people by 2030. ITW has affiliate NGOs in Uganda for 14 years and Malawi for 5 years, with other country registrations in progress. The original seed foundation was from the Gates Foundation, but the organization is now funded by grants, private donors, and research. Today, the ITW Africa teams are expanding services throughout rural Uganda and Malawi, with offices in both countries and a new center for health education, research, and innovation in Kampala, Uganda, that will benefit future expansion to other countries. Let's look at the strategy ITW uses to address specific problems with imaging using the Global Burden of Disease Study, referred to as GBD, the most comprehensive worldwide epidemiological study to date. Although not perfect, the resource includes data on morbidity and mortality from 1990 to the present for 204 countries and 369 diseases and injuries. A forecasting platform called the GBD Foresight that I'm showing here was developed to predict the future burden of disease with the top 21 causes of death out to the year 2040. The key is that almost all diseases, either directly or for their related complications, require medical imaging for prevention, diagnosis, treatment, or surveillance, with communicable diseases in red, non-communicable diseases in blue, and injuries in green. Here we're looking specifically at Uganda with causes of death per 100,000. We note that maternal disorders are in the top 10 and are predicted to remain on the list for another 20 years. Pregnancy is the leading cause of death for teenage girls in sub-Saharan Africa. Let's jump over to this map that shows the worldwide maternal mortality ratio, or maternal deaths per 100,000 live births, where dark red, mostly African countries, is the worst case situation. In fact, Uganda and Malawi have the highest maternal mortality in the world at about 440 deaths per 100,000 live births. Addressing maternal disorders as a first step was low-hanging fruit for ITW, but over the years, we've expanded ultrasound to other conditions as well. When we drill down to what causes such health disparities, not just for obstetrics, this map of Uganda helps give one clue: an access to care issue. Most deaths occur in remote, underserved areas where there's limited access to appropriate medical care. For example, 90% of Ugandans live in resource insecure areas, while 90% of trained workers live in the urban areas. There are 4 major areas where insufficiencies lead to gaps in access: workforce, technology, infrastructure, and quality management. I'll focus on workforce. This map from the IAEA Imagine database with information from over 170 countries clearly shows the radiologist workforce shortages in yellow, mostly in low or low to middle income countries. The Lancet Commission on Diagnostics predicts a global diagnostic workforce shortage of almost 1 million by 2030. It may be unrealistic to expect resource-constrained countries to increase their workforce capacity to the level needed. For example, this slide demonstrates the workforce shortages in Africa, with ratios beginning at 1 radiologist to 23,000 people in Tunisia on up. The ratios are really hard to process. I think we can all agree that it's impossible for 1 radiologist to manage the imaging care of 8.8 million people in Malawi. We need to think of outside the box, contextual solutions that might include team-based working, task sharing, changes in radiology educational programming, and improved continuing professional development. As one solution over the past 14 years, ITW deployed a unique solution to equip rural health facilities with ultrasound essential packages that include modern ultrasound technology and infrastructure to support scanning, including IT, a supply chain, as well as maintenance and repair, training and supervision over 2 years, followed by indefinite quality management with remote consultation and peer review, and introduction of a sustainable business model. ITW has a robust IT infrastructure. This is the basic workflow that can be used for any utility of ultrasound. A patient enters at the health center or point of care. The provider performs a basic ultrasound scan and gives a preliminary report, but also performs a sweeps protocol, which is proprietary to ITW. Those images are compressed and sent over the intranet to a cloud-based server where they're interpreted by experts. If there's any comparison discrepancy, the discrepancy is called back to the provider at the point of care. This IT model is basic, but it's used over and over and over again for remote consultation, research, teaching, and quality assurance. And because we developed a train the trainer model over the years, most of the experts are now local. While ITW had a catchment population of only 22,000 in 2010, the impact is now 3.2 million. The utility of ultrasound for other disease conditions is magnified because we can use the same trained staff, ultrasound machines, and remote consultation for different body parts and diseases. Problems are intercepted early before they become acute, end stage, or fatal. For example, 30% of obstetric ultrasound scans in rural sub-Saharan Africa lead to referral for a higher level of care. As an interesting outcome, when we place a scan machine at the rural health centers, we see what we call a preventive health magnet effect. We see a 70% increase in women returning to the clinic for prenatal care, allowing us to test and treat for comorbidities like malaria, worms, TB, HIV, anemia, and hypertension. The centers where ultrasound is placed become financially sustainable after 2 years. Good inquiry and scholarship have led to evidence-based outcomes and advocacy that have shifted policy at the Ministry of Health level. Ultrasound technology has improved drastically over the years. There are now many modern ultrasound systems on the market that are fit for purpose for rural areas. These are portable, rugged, solar-powered, easy to disinfect, user-friendly, and of course, safe. Most include remote teaching software and are tablet or phone-based. Moreover, we can use the same machine to evaluate many different disease conditions. Last year, we trained over 50 intensivists at the National Hospital in Kampala and first responders in the community to perform lung ultrasound for COVID, important for diagnosis and triage, as well as monitoring. ITW brings expertise in ultrasound imaging, not limited to obstetrics. A recommendation from the World Health Organization is that stakeholders could reduce the total cost of prenatal ultrasound if the scan equipment is also used for other indications. Over the years, we've extended ultrasound services to look at the heart, lung, abdomen, pediatrics, trauma, and cancers. This photo is from a breast cancer program. This is a volunteer pediatric radiologist scanning a child for extrapulmonary TB. This is a cardiologist from Children's National Hospital in Washington, D.C., doing a rheumatic heart disease study. There's a history of service learning projects with students, medical students, and residents, as well as a pipeline for faculty and other professionals to engage in clinical or research projects. This is one of our residents who received an ACR Goldberg Reader Grant to do an elective in Uganda and Malawi. He's now on faculty at the University of Vermont. There's a growing body of evidence describing the use of ultrasound for diagnosis and treatment of many infectious diseases, including neglected tropical diseases like schistosomiasis, my past, and echinococcus. We're starting to focus research and clinical service in these areas too. Supportive infrastructure and resources include administrative offices in Uganda and Malawi, as well as the newly built Center for Health Education Research and Innovation. We're already conducting health services research in Uganda and Malawi. We work with transdisciplinary teams, including local academic researchers with associated peer-reviewed publications and presentations at scientific meetings, as well as many new grant awards. ITW has long-term relationships with key champions and sponsors, including government ministries, offices of prime ministers, local academic institutions and health providers, cancer institutes, and local community health workers. Because good health is dependent on many social determinants, we also partner with other cross-sector organizations that help us address the situation holistically, including those focused on clean water, nutrition, solar energy, primary school education, vocational programs, and gender equity. There are strategic relationships with other academic, industry, and funding partners that help us build capacity in other areas, such as using ultrasound to diagnose and treat occupational shoulder injuries, as you see in this photo. Finally, ITW brings very difficult to find on-the-ground know-how. The organization works with 4 different institutional review boards in sub-Saharan Africa and understands the research processes as well as the country rules, regulations, and health services strategic plans. Our teams are well-versed in local supply chain and procurement. There's a high level of experience with implementation of programs and subsequent monitoring and evaluation. An upfront focus on implementing within the local cultural context and customs under the guidance of ITW Africa leads to better outcomes. This is the first graduating class in Malawi trained by Ugandan radiologists seen here. So our mission is to figure out where we can have the greatest impact. A recent grant allowed us to expand to refugee settlements in northern Uganda to communities that had no access to prenatal care, where we can significantly impact lives. We didn't slow down during the pandemic. Our training and clinical services continued. A partnership funded our new facility in Kampala, Uganda, that will host myriad opportunities for imaging education, research, and innovation going forward, including for AI and machine learning. Local capacity building of talent, including for education and research, is a core value of ITW. And these are the radiologist teams at the Imaging the World Sherry facility. New expansion leads us to other areas of Malawi and Uganda, like the remote islands in Lake Victoria, in collaboration with Rotary clubs from the United States and Uganda, sponsored by Rotary International and endorsed by the American College of Radiology. So if you look here, these are the islands where women in labor with complications must travel in dugout boats through hippo and crocodile-infested waters to reach help on the shore. If we can give them knowledge of obstetric complications way in advance of delivery with a subsequent stay at a hostel near the hospital on the mainland, we can prevent catastrophic outcomes. This is the first class of graduates that will work in the Sussex Islands, and they graduated last week. Our organization is made up of volunteers. We're all volunteers in the United States, with the only paid staff in Africa. Volunteer opportunities include clinical service, teaching, research, quality management, and development. For those who want to teach, we instruct in the multimodality and subspecialty curriculum of 2 radiology residencies in Kampala. There are travel options as well as options for those who want to volunteer from this side of the ocean. With a few months' notice, we can arrange practitioners' licenses for those wanting to do clinical service, and we have our own malpractice insurance. We also have travel insurance, but you need to get a small supplementary policy if you want to go. Both countries are very safe. We travel in ITW vehicles with our teams, and I've never had any fear, even when traveling with my children. Malaria is a risk, so you'll want to visit the travel clinic for prophylaxis before the trip. Otherwise, there are no blocks in the road to volunteering. Thank you so much, and you can reach us through the website. This is the QR code on the top, or you can email me directly. Thank you.
Hello, and I want to start by thanking Doctors Nathan and Pyatt and the RLI for inviting me to speak to you tonight. My name is Frank Lexa, and I am extremely honored to be speaking with such a distinguished group of the other 3 speakers. They're doing tremendous work, and I'm going to take things in a little bit different direction and talk to you a little bit about how the RLI is now doing international radiology outreach in non-clinical education. As you heard, part of my job is to do international work, and I've been fortunate to have had a lot of opportunities to work internationally. I also just want to share some general observations and build on what the other 2 speakers have talked about how to do this successfully, and how to take your good intentions, your energy, your idealism, and your skill sets, and then use them successfully in doing international radiology outreach. And I have no disclosures that are relevant for this presentation. Again, I want to thank Drs. Nathan and Pyatt for the invitation. I really want to thank Anne-Marie Pasco and Jennifer Pendo and their entire team at the RLI for all the great work that they've done. And I'm going to be focusing on one of our projects here. And also to Dr. McGinty, who in her current role at the International Society of Radiology, helped develop this opportunity to collaborate and do international work. My goals for this talk, and again, it's going to be a short talk, as are all the others, but try to provide perspectives on how to succeed in international outreach and how to succeed in building relationships, in doing good work, and also just in having a good time and having this be personally fulfilling for yourselves. By talking about non-clinical education, I hope this helps widen the horizons of what transnational outreach in radiology can mean. And I have also done clinical work in radiology as a volunteer, and I have done clinical education in radiology, but understand that there are other things that we can share, other ways that we can learn from each other, because as I'm sure you'll hear from the other speakers, and it's certainly been the case for me, is that I always feel like I come home with much more, and that I'm learning a lot from the people I work with and the friends that I've made and the colleagues. But just understand that there are other things that we can also bring. And it's so inspiring to hear what the other speakers are talking about here today, because again, the kinds of things that we can bring and the kinds of things that can be very helpful. And I want you to avoid some of the pitfalls that limit effectiveness in global education efforts. And I first piece of advice is to go with an open mind. And as you heard from Dr. Pyatt, the first work that I did overseas after finishing my training in the US was actually to go and work in France. And, part of my background is French, so please don't, send me emails saying I'm making fun of French people, but it was quite different to be there. And I worked at the University of Bordeaux and was helping with the implementation of some MR protocols and also doing a lot of catheter work in neuroradiology and just a lot of things that are different. The difference with Philadelphia with regards to what is an emergency. There are very few emergencies in France, at least between noon and about 2 or really about 2:30 in the afternoon. And, we had some very interesting experiences with dealing with the French military because they do a lot of the trauma transport and, just learning different ways of handling problems, slightly different types of diseases that are treated, different ways of working diseases up. Very interesting to go to their conferences and understand what's surgical and what isn't. So just take an open mind and understand that however you've been trained, wherever you've been trained, just understand that there are many ways of doing things. And then as you go, further into travel and as you work internationally, have all kinds of interesting experiences. But again, keep an open mind. I still haven't told my children what we were eating that day in Kazan, and that's in the sort of Central European part of Russia. And, when I was working in Ukraine, very different ways of, dealing with some kinds of medical problems, very interesting ways that colleagues are making do as they were rebuilding the country at the time, and very interesting stories of what it was like to be there during the Soviet times and immediately after the Soviet times. And certainly as you build relationships and as you make friends, you also get very different perspectives, and certainly my perspectives on current events of the day that this is being done are very different than somebody who's never been there and only gets their information from cable news or wherever you're getting your information. But just tremendous friendships. And again, a lot of very interesting back and forth in exchanging. Then again, not to again make fun of France, but this is from Nancy, near where my grandfather's family came from. And that's me doing my talk. And when I do talks overseas, whether I'm actually doing them, trying to do them in French or Spanish, or if somebody's doing translations for me as they had to do in Russia and Ukraine and in China, I don't do humor and I don't do sarcasm, even though everybody knows I'm homozygous for the sarcasm gene. Play it straight. But then in the middle of my talk, people start laughing at an inappropriate time in the talk. I'm talking about AI, but it's because only in France would you have somebody here doing caricatures of the speakers, and that's supposed to be me, kind of like Uncle Sam with a little robot who's the AI. And just understand that there are lots of different ways of doing things, and take an open mind, because to do this successfully, you really have to understand the people you're working with. And even when you think you understand, you may not. And I'll give you another example, personal example. I was invited to go to Kampala, Uganda. This was back in 1997. I was actually invited years before, but couldn't go because there was, it took forever to set it up. I went back to go to graduate school when it actually occurred, and managed to carve out some time and went. And I knew that they didn't have an MR system, so all I had was literally a battery-powered old CT scanner, battery-powered because of issues with the power grid. And I figured they didn't know anything about MR, and I had done my homework, I thought. I get there, and I find that these residents know more about MR than many of the residents that I had back in Pennsylvania, and it's because they had access to the internet, and they were just doing cases every night on the internet, and they knew a lot about MR. So I had to up my game and come up with better cases for them. So just take an open mind, and then keep be flexible and resilient. There are a lot of things that you need to keep an eye on as you look around the world, and certainly things like disease incidence, the stage of disease. Once I started to do work in Africa, just back in Philadelphia years later doing clinical work, and some medical students had been to Tanzania, and so they brought back a bunch of cases, and they said, would you mind taking a look at a case with us? And I said, sure. And then the next thing I know, I was reading a lot for them, and that certainly the stage of disease at the time these MRs were done in Tanzania, very different than what you would see in the States. And it actually changes your differential diagnosis as a neuroradiologist. And there are these differences, but also just keep in mind that when you start to do non-clinical work, and that's what I'm going to talk about with the RLI example, we also have to take into account economics and political structure and societal values and how power is distributed in the system. How do doctors relate to the government? How do doctors relate to each other? Some of the other issues that were brought up, which is sort of, in some cases, gender, class, and racial issues in how doctors relate to each other in the hospitals. If you want to talk about leadership, you have to be willing to tackle these sorts of things. And leadership structures are very different in some of the other countries that we're talking about here. Now, in the RLI, we have developed a series of programs that work well in North America, and particularly work well in the US, with how to get people up to speed, particularly people like many radiologists, many people in medicine and STEM backgrounds who may not have had a lot of leadership training. And then all of a sudden they're in the mid-career and then they need leadership training. And we've sort of broken this down into ways that we do things. And we talk about leading yourself and then leading teams. And since we live in interesting times, leading change. And that's what a lot of leadership work is really about. It's about changing things and hopefully changing them for the better. And that's really what we're talking about tonight. But we built these workshops, but then obviously when we go to another country, when we're working with people in another country and doing it remotely as we had to do because of COVID in this example that I'm going to show you, it needs to be something that's relevant. It needs to be in its entirety relevant to the people who we're working with. And we can't just take something that makes sense if you're in an HMO in California and take that overseas. That's obviously not going to work. That's just an extreme example of the sort of meme of creating, talking about a first world problem, or at least part of the first world, and maybe even a more narrow part of that. You really need to listen and understand what the other people, the people in your audience, the people who are participating as learners are going through. And so when we put this together, we started off with some preparatory discussions, and we decided that for our first program, we were going to work in Zambia and Lusaka, in the capital. And again, because of COVID, this was done remotely. As we talked with a leader there, Dr. Veronica Shisha, as we talked with her, we realized that we really needed to up our game and really start with focus groups and surveys. We needed to talk to members of their community to make sure that the content we developed was spot on for what they needed. So this is really a collaborative effort. And this is different than just showing up with a lecture kind of thing that I might have as a neuroradiologist, cranial nerves, where it's kind of boilerplate. You can make some adjustments for where you're working, depending on technology and the prevalence of disease. But at the end of the day, it's going to be pretty similar wherever you give it. This has to be done collaboratively. We need to know how your system works. We need to know what leadership issues you're facing. We need to understand all of this. And the team did a great job with putting together a web page. We built this live interactive workshop session, which included discussion of real world scenarios, how people handle power relationships, how they deal with challenges in the workplace. And this was not a one-off, because that's not how we work. We are doing a post-event evaluation, and we've got follow-up and mentorship planned. And this worked well. And we're planning on doing this in several other geographies in 2022 and expanding this hopefully into a global system. This is what the workshop looked like. There were on-demand learning modules available in advance, and these were recorded. We had 3 tremendous faculty members, Hart Beatty, Geraldine McGinty, and Ryan Lee, kind of a dream team of 3 great speakers. They did a fantastic job, but again, this was done collaboratively. And I'm proud of them, but I'm also just proud of how this all came together, because it really took collaboration to make this work. And I know this has been all too brief, but this to me is just an example of how you can move into a new territory where there is a need and where there's an international appetite. And as I've let people know about this, and as people have heard about it, we've got a lot of international interest, but it takes a lot of work. And just like learning to adapt when you're doing radiology clinical education or where you're delivering care, you need to find out what's going to have the highest impact and do the most good. These non-clinical domains have additional opportunities and pitfalls. People have different relationships with their government, and you need to make sure that you do your homework. And it really starts with listening. And you really need to listen first, ask the right questions, and listen some more. And that's how you get started, and it has to be an iterative process. In the end, it needs to be culturally specific and culturally valuable. It has to be bespoke. It has to be tailored to what people need, and not boilerplate, because the problems are going to be different. At least the things that matter most are going to be different. And that's where you can have the high impact. So thank you so much for listening. And thank you again for the invitation to speak today.
I'm going to be taking a little bit different approach than the other speakers. I'm going to be providing what the college has been doing in the international outreach front for some time. I want to thank Dr. Nathan and Dr. Pyatt for agreeing to have us present as well, and the outstanding faculty, Dan Melora, Kristen DeStichter, Dr. Frank Lexa, all who've done a tremendous job laying out their vision. Okay, so I will be going forward. Thanks again to Dr. Pyatt and Nathan, Dr. Melora, Dr. DeStichter, and Dr. Lexa. Okay. So the ACR's foundation's history. Back in 2003, we had a presentation for an honorary fellowship that was given by Dr. Diefenthal, who many of you know or may know. He was at KCMC and was responsible for assisting in bringing radiology to sub-Saharan Africa. Dr. Diefenthal did not get up and talk about all of his accolades in receiving the award. Rather, he challenged the college to get involved in international outreach. In 2003-2004 timeframe, Jim Bortstead became the chair of the ACR, and he moved the ACR's activities to the foundation, and we began. In 2004-2008 timeframe, we established a website for international service. We provided donated materials for those who requested them, and we started a program with Iraq that I'll talk about momentarily. In 2009-2010, we took over the assets of the former Radiology Outreach Foundation, which had been involved in international outreach for 2 decades previously. We established some needs assessment, we increased our donations, and we established the Goldberg Reader Travel Grant and the Haiti Radiology Relief Fund. I'll talk about those coming up. We continued to work in those areas for some time. And as some of the NGOs like RadAid, like Imaging the World began to mature, the college has begun moving its thrust of its programs in different directions. We are doing more to collaborate with existing organizations now. We established the Global Humanitarian Award Program to recognize outstanding service, as well as to promote international outreach. We've been involved in the development of MOUs and grant assistance. We've assisted with RadAid in utilizing our case in point program for educational purposes. As has been mentioned, and Dr. Lexa just mentioned this, that the RLI has worked now to establish a program for leadership in low to middle income countries. And the ACR has been working in our quality and safety area with PAHO to assist in programs that are put in PAHO countries. So here's a breakdown of these programs, and I'm going to go through this really quickly to save time for questions and answers. I mentioned the Goldberg Reader Travel Grant Program, and I'll touch on that later. Same with the Haiti program. We're in the process of updating our facility profiles due to some staleness of the information. Our donation program has ostensibly ended. I'll talk a little bit about the Observership program. I've talked a little bit about these other programs with more detail to come. The Goldberg Reader Travel Grant Program was started in 2008. We sent the first two to Moshi, Tanzania, where Dr. Diefenthal was located. We have had 50 residents participate in 30 different countries. The applications on the ACR's website. The residents or the fellows can serve up to, or have to serve at least a month. They'll need to get a letter from their institution or program, and they'll need to have specific goals laid out to be assessed. The International Outreach Program in Haiti. This was our first boots on the ground mission. We did this in response to the earthquake in 2010. We established radiology education days for the first 3 years that we were there. Then we worked with Imaging for Change and RadAid and some other organizations to reestablish a radiology residency program at the University Hospital. I'm proud to announce that the number of radiologists in Haiti has increased threefold since we were there in 2011. At that time, they had 19 radiologists serving a country of 10.5 million. We've also been asked to assist with a radiography education program, and ASRT is going to be working on that as well. And we're continuing our assistance at the residency program in Capital. Here's some pictures of that initial mission that we had post-earthquake. This is from Grace Children's Hospital in Port-au-Prince. That is the second floor. Ostensibly what happened was the roof collapsed. You can see an infant's bed there. Amazingly, they had very few casualties, but many injuries. They spent months outside under a tent working to keep the mission of the Children's Hospital alive. You're seeing Paul Ellenbogen looking out, the person bending over Chuck Phelps, who introduced us, and you can see the films that are getting dried out outside. There's some other pictures. We had donated a Siemens hybrid radiography machine. We also did ultrasound, hands-on ultrasound. The facility that you just saw, pictured 2 years later, of that second floor being built, and I can say has been completed at Grace Children's Hospital. Here are the folks that went through the residency program. You'll see a smattering of volunteers that went. Volunteers came from SDMS, ASRT, ACR, and some other organizations. And Chuck Phelps was the guy in the bottom right-hand corner that introduced us to Haiti, as I mentioned previously. The facility profiles, I said they're in flux. This is what they did look like. When we took over the Radiology Outreach Foundation's assets, the best cachet that we got out of that process was contacts at over 200 facilities throughout the world. We went out to them, asked them to fill out information to help us identify volunteer opportunities. This has now been put on hold because a lot of the information has become stale, but we will be reintroducing this program in the days to come. And if anyone is interested in a volunteer opportunity, certainly they can contact me at the ACR, and I'll work with them in trying to provide what their needs might be. We discontinued the ACR donation program. We had gotten very generous supplies from RSNA, ESI. Individual members sent us some of their old things as well. But with the world becoming much more digitized, a lot of the educational materials are now done that way, and it saves us and saves the program money. Talked a little bit about the Iraqi Observership program. Ostensibly what this was we brought over young radiologists and staff from the largest hospital in Iraq, and they came and learned a number of things to keep their skills up to date. Most of them ended up going to the University of Michigan and doing the work there. So thanks to Reed Dunnick and that hospital for its assistance with that program. And they did not have an IR lab. They did not have PACS until these young folks came over, saw what we had, and ultimately were able to implement those programs into their hospital. The Goldberg Reader Travel Grant, maybe our most popular program. It's been around since 2008. It's named after Barry Goldberg and Mo Reeder, who were important in the development of both tropical diseases as well as the ROF. We've had 50 recipients from 30 countries. The requirement is that you serve 30 days. You work in a radiology specific area. We've had folks from ITW, and I thank Kristen for a shout out there, and Rad Aid programs that have received the grants. It must have a recommendation from both your the host institution where you're going and the academic program. It's really important to also understand that you have to have very specific radiology goals built into your application, because that's where the applications will be assessed. We have a global humanitarian program. We've got 3 award categories: individual radiologists, organizations, including nonprofits and industry groups, and non-radiologists. They can either be self-nominated or nominated by a peer. We've had 18 award winners to date, with 2 more to be added in 2022. And you'll hear more about that in April. And I want to thank and congratulate again Dr. DeStichter and Imaging the World, Dr. Melora and Rad Aid International for being I believe the 2nd and 3rd recipients of the award. Actually, Rad Aid, I think, was the first year, and Imaging the World was the 2nd year. Like I said, we have had this shift in what we've been doing to ensure that the resources are well utilized and we're collaborating. We've developed MOUs. One of the MOUs Kristen spoke with, or just spoke about, in the Sicily Islands and Uganda, supporting the program that she has there and the great pilot and the tremendous success that's come out of that program. We're also working with the Rotary Club on that endeavor. We're in the process of leveraging the college's grant assistance that we do through the National Institute, and leveraging that for international outreach. We're working with the Rotary Club in that, and potentially other groups. We've worked with Rad Aid, in case in point, I talked a little bit about that. Frank just talked about the leadership program with RLI, Assistance to PAHO. This is really kind of where we've been going, but we will still help you with your volunteer opportunities. So one of the questions, I am not a clinician, I'm a staff person, and I've had the great fortune of being able to travel both to Africa and to Haiti. And one of the questions that I ask folks is, what was the experience like for you? And almost universally, the response comes out something like, it made me recall not just why I became a radiologist, but why I became a physician. It's a very moving experience. You're going to be involved with patients and patient care. When I went to Haiti for the first time, the person that assisted us in getting in there tapped me on the shoulder and said, as we were boarding the plane, Brad, be careful. Once you get into Haiti, Haiti will get into you. And I could probably think that Kristen and others that have worked in these situations recognize that that is indeed true. And that's what I have.
Okay. Well, thank you to our excellent faculty this evening. It was really incredible to hear about all the great international work that you have all done. So we are now going to move on to the Q&A session. So just as a reminder, to ask a question, you click on that Q&A icon, type your question, and then hit submit, and we'll see it on our end. We do already have a few questions that have rolled in. First question is, how can I get involved? Do you have any recommendations for initial steps?
I'll start and let Dan and Kristen take it from there. Kristen mentioned ways to get involved with Imaging the World. I know Dan has a tremendous outreach effort with the chapter program that they have in Rad Aid. For the college, there are other NGOs that are out there that are doing this type of work. We take a look at what some of those groups are doing. And then we try to identify where, you may have a specific interest. If we have some knowledge, we will go ahead and have you contact directly someone from a facility that you could potentially volunteer at, or we would simply refer it to an organization like an Imaging the World or Rad Aid to work on one of their programs. Dan or Kristen, do you have?
Yeah, I can chime in. Thanks so much for this webinar and for having everyone come together. One of the things I've put into the chat bar through the course of this webinar, because others have asked similar questions. So there is a link there to apply. The reason why we ask you to submit an application is so that we can learn a little bit about you, what modalities you're interested in, like CT or MRI, X-ray, ultrasound, or what languages you speak, or what you're interested in terms of places to go to, that kind of thing. So the application is there, and we would encourage you to fill it out, and it helps us to match you to the kind of project that might interest you. One thing that I will say, if you go to Rad Aid's website, some people love to go straight to the Where We Work page because they want to see if they can find a country that they're interested in. And they're not so much concerned about what they do, but they want to go to a particular place. Let's say you'd like to go to Kenya, or let's say you speak Spanish, so you'd like to go to one of the Latin American programs that we have. So some people love to go to the Where We Work page. And then some people like to go under the What We Do, because there you'll find things organized by types of projects. So if you're interested in artificial intelligence or informatics or ultrasound or IR, you can look under there, and you can also see that we have some grant programs and some things you can look at. So it's up to you. You can get involved through the what you'd like to do, and you can also get involved through the where you'd like to go. And if you're open to anything, I recommend you go to our general volunteering page, and that's where I would start.
I can go to, I would say that the best way to get involved is to contact me via email, and I will send you our volunteer intake sheet, and then we'll figure out, according to your skills and talents and passions, where you best fit into the organization and determine when you want to go. If you're a medical student, the best time for you to go is in between first and second year, and in fourth year. If you're a radiology resident, obviously the fourth year is the best, but if at all possible, if you can find a week to go sometime in your first 3 years, planning to go for an additional month in your fourth year, that's what we consider to be optimal. And we help you plan projects for that, usually research. And if you're faculty or even retired or early career, wherever you are in your trajectory, your skills can be used as a volunteer. And we usually also are able to find volunteer opportunities for spouses and other family members if they come along, because we have a lot of connections in the country. We also have a big program for high school students during the summer. So if you're, you have somebody who might be interested in that, you could send those individuals our way as well.
Dr. Alexa?
I would just add that please start, if you're not already involved, get involved with the RLI. And as we used to say with the Wharton students, if you have leads, if you have ideas for people who might be country champions for some of the international work that we're thinking about, please let us know, because we would love to hear from you.
Any other comments? Okay, next question is, how is malpractice insurance handled if you read exams internationally? Is there some sort of international licensing procedure?
I can take that. We have international malpractice insurance that covers practitioners who practice in Uganda or Malawi. And we have a process to get practitioners' licenses for individuals who want to do clinical service. If you want to go just to observe, you don't need to have a practitioner's license and you don't need malpractice insurance. If you're going to go and do some true clinical work, then you absolutely have to have both a practitioner's license and malpractice insurance. And there are some certain things that go along with getting the practitioner's license. You have to have a background check. You have to submit your CV. You have to fill out an application. But we run all of that through our team overseas, and they process all of that for you. So it's pretty painless once you send in your information.
Yeah, so the issue of malpractice insurance is important because it depends on the role that you're really going to be taking on. Since Rad-Aid's in a role of supporting those who are the patients, physicians, and care providers, technologists, nurses, et cetera, most who go as educators are already covered under our agreements with the partner hospitals. So they're as educators, so they're not the care provider. And in that education role, there's a path for that. If those people who are going to be taking care of patients either on site or remotely choose to have a temporary form of malpractice insurance, there is a form of malpractice insurance. It's a small charge on a daily basis, and those who go can take on that insurance. So it turns out that there's a variety of mechanisms and some flexibility for those volunteers who either want to do a direct care pathway and have insurance versus those who want to be in an education support role or a capacity building role.
Any other comments? Okay, so I think we have time for one more question. Next question is, how would you start a global health chapter in a radiology department? Any suggestions?
So I put into the chat bar there's a Start Your Own Rad-Aid chapter page on our website, and it's an easy process. There's about 85 Rad-Aid chapters at ACGME accredited institutions. So if you're interested, just go under that part of our website or just look in the chat messages that I put there. You can go there and you can apply to start a Rad-Aid chapter. And that's one way I would suggest. I think there's other organizations that also offer chapters, but that's the one we've got for you if you're interested in.
We don't have chapters, but residents from any program across the country or their faculty may volunteer with Imaging the World.
Any other comments? Okay, so we do want to be respectful of everyone's time this evening, so we're going to go ahead and conclude the webinar. So I'm now going to turn things over to Dr. Pyatt.
Thank you, Jen. We have had a superb and very inspirational program this evening, and we sincerely thank Drs. DeStigter, Melora, Alexa, and Brad Short. Thank you for this really fine program. We have a few other comments here at the end. First off, I wanted everyone to know I serve as chair of the FACR committee for the ACR, and we want you all to know that we are seeing a lot of radiologists who are doing international work, and we have updated the nomination criteria to include recognition for radiologists who do participate in international and humanitarian service like you're hearing about tonight, and that can be part of nomination criteria for the FACR honor. Please share your feedback with us. We will be sending a post-webinar survey by email to you, and the recording of tonight's program will be available next week. The next Power Hour topic will be held on Wednesday, March 30th from 7 to 8 p.m. and the topic will be pandemic impact on the workforce. It's quite an interesting program in development. And you can register for that program or any other Power Hour webinars at acr.org/Power Hour. Again, thank you to our tremendous faculty tonight, and we hope we have expanded your horizons and maybe have gotten some of you interested in participating in international outreach. Thank you, everyone.
Thank you, everyone.
Good night.
Thanks, everybody.
Night.
Thanks.